Welcome to Parasitic Diseases. Today we're going to discuss a potpourri of nematode infections, lumped together in this following title called Nematodes of Minor Medical Importance. Now, the only thing that makes these minor medical importance is the fact that you or I don't have it. So, whichever one of us catches these first, that they now become nematodes of major medical importance. So, not to add levity to this, because these are not fun to catch, but some are more serious than others, as we'll see in a moment. We're going to discuss Manzanilla ozzardi, Manzanella perstans, Manzanilla streptocarpa, Dirofilaria immitis, Capillaria hepatica, Capillary Afilip, Esophagus bifurcum, and Turna diminutus. They're each among the world of nematodes a short story in the pathogenesis of diseases caused by nematodes. So let's begin with Manzanella ozzardi. Now, you might guess by the name Manzanella that this might have some connection to Sir Patrick Manson, and indeed it does. They've named this organism after what has now been recognized as the most influential parasitologist of his time, Patrick Manson, who later on became Sir Patrick Manson. So Manzanella ozzardi is a filarial nematode. It fits into the same pattern as Wuchereria bancrofti, Brugia malei, Onchocerca volvulus, Loa loa, and Dracunculus medinensis. It's a vector-borne infection, as all filarial nematode infections are. It's found in South and Central America and throughout many Caribbean islands as well. Its vectors include now midges and black flies. So now it's not just crossing over from culicine to anopheline mosquitoes. It's going from one whole group of dipterans, the midges, to another whole group, namely the black flies. And in both cases, the parasite survives equally well. The adults live in human adipose tissue, in the peritoneum, or in the thoracic cavity. The microfilariae circulate in blood. There's almost no specific clinical disease associated with this infection. When I say almost, that is to say, people with Manzanella ozzardi complain of chronic arthritic conditions in the long limbs, particularly in the joints of the fingers and the toes. The diagnosis for this infection, of course, is to find evidence of the infection in the host, and blood is the likely source to find the microfilaria. It's identifiable and distinguishable from all the other microfilaria of the filarial parasite family. So we can make a diagnosis. We can actually treat this infection using ivermectin. And if you want to really control this infection on a worldwide basis or a global basis, at least throughout South and Central America, you have to reduce the vector populations. And that's proven very difficult. Indeed, since midges and black flies, both completely different biologies, carry the same parasite. So it's recommended if you visit these areas, let's say you're on vacation and you want to have a good time, include DEET in your packing material and wear it whenever you go out in the evening or early morning. And you should repel the insects that are responsible for transmitting this infection. It remains of minor importance, as no major clinical disease has ever been associated with it. Short story number 1. Moving on to short story number 2. Manzanella perstans, another nematode infection, a filarial nematode named after Sir Patrick Manson in his honor. Only this one has a larger distribution in terms of geography. We can now find it throughout Africa, the Caribbean, and South America, so it's widely distributed. In this case, though, it's restricted in terms of its biology to biting midges only. So black flies are out, mosquitoes are out, only the biting midges are included in the vectors that are responsible for this infection from person to person. The adult worms live in the serous cavities, the thoracic, the peritoneum, the pleural cavities. Adult worms harbor Wolbachia endosymbionts, and the significance of that is yet to be understood. Filaria circulate in blood. And in this case, we can now relate this infection to several other Pathological conditions caused by other filarial nematode infections, particularly the calabar swelling aspect of this infection, is very similar to that found in Loa Loa, but in Loa Loa, the calabar swelling migrates with the worm, and since the adult worms in this case remains stationary in their local niches, the calabar swelling is associated with various parts of the body that correspond to the peritoneum, the pleural cavity, thoracic cavity, etc. Identify the microfilaria in blood, and you've made the diagnosis. Now we have a little departure in terms of its response to various chemotherapeutic agents. Ivermectin has been used, but is completely ineffectual against this parasite. A commonly used antibiotic, though, doxycycline, appears to be very effective in treating both the adult and the microfilaria in the blood. Prevention and control, again, focuses in on controlling the numbers of biting midges. Very difficult, very, very difficult. These are insects that breed along the coasts of all of these Caribbean islands and in South America and the Caribbean, off the coast of Africa. Very, very difficult to deal with indeed. DEET's a good, effective means of repelling them. So just, again, be aware of the fact that tourists have to really bring repellents with them in order to survive some of these infections. The third Manzanella is Manzanilla Streptocarpa. It's a filarial nematode as well. It's localized to Central Africa. Biting midges, again, are the culprits in terms of transmission from person to person. And the adults and microfilariae live in the subcutaneous tissues, reflecting a little bit the biology of Onchocerca volvulus. A pruritic dermatitis and hypopigmented macules in the skin are the result of infection and sometimes can be confused for early onset clinical symptoms and signs of infection with Onchocerca, but obviously doesn't progress to the degree that Onchocerca does. Diagnosing this infection is made, though, the same way as you would find the microfilaria of Onchocerca, namely in a skin snip. In this case, the microfilaria has a little bit of a hook on its tail, as illustrated here, and that distinguishes it from the sort of an S-shaped microfilaria that was originally identified for Onchocerca volvulus. We can treat this infection with diethylcarbamazine or ivermectin, but since this parasite is found in Central Africa, remember the caveat with regards to diethylcarbamazine. You have to make sure that the patient is not infected with Loa Loa first before instituting chemotherapy. Controlling the numbers of biting midges, again, is the approach that's most successful. And in the era, let's say the 1950s and 60s, when DDT was being used indiscriminately, it was a very effective way of controlling a great number of insect populations, including biting midges. But many of them have become resistant to that insecticide in the meantime. Again, for people just transitorily visiting these areas, DEET is the recommended repellent of choice. Now we come to an interesting filarial parasite, which I think has a cosmopolitan distribution, a global cosmopolitan distribution. That is to say, it's found wherever we are found, and it's associated with our pets. So this is a filarial infection that goes by several different species names. The most common name that we know, the most common species, I should say, is Dirofilaria immitis, and it's also known as heartworm. And I'm sure a lot of you have seen the ads for veterinary products on the wide screen at home, so to speak. And heartworm is always the one that they're aiming their chemotherapeutic agents at, because it's a very serious parasite of dogs. It's vector-borne, and mosquitoes are the culprits in this case. Both Kildocene and Anophelines. The adults live in the heart chambers, right inside the heart. Humans are aberrant hosts, and the adult worms first locate to the heart, and there they die, because we're obviously a little bit different than dogs in terms of our biology, in terms of our chemistry. As a result, the worms are not able to survive to fully reproductive adults. In humans, when they die in the heart, of course, the worms are then pumped up into the lung fields, and that's where they stay. They die, and then they calcify. This creates problems for clinicians that see patients with ring-enhancing lesions in their lungs. It's very often mistaken for early onset carcinomas, etc. And the only way to make the true diagnosis of this is to find the offending organism. Now, a biopsy is usually what happens in some cases because indeed it is mistaken for a cancer. When the cancer is then excised, in quotes, and examined histologically, and you see calcified cross-sections of worm, the definitive diagnosis is made, but a little bit late to avoid surgery in this case. There are immunological tests available for making the distinction between ring-enhancing lesions due to carcinomas and, of course, calcified adults of Dirofilaria. We have a lot of this infection in North America and throughout Mexico and South America as well. So if you were a dog and you acquired this infection, you become compromised in terms of your cardiorespiratory functions. You start to lose your pep and energy. You're not processing a lung's worth of air the same way as you would if these worms were not occupying a portion of the chamber of your heart. So treating dogs for this infection on a routine basis is an effective way of controlling heartworm in pets. If the clinician can make the connection between the presence of a coin lesion and a pet ownership, or perhaps this is a kennel owner, then a clinical diagnosis can be made and no treatment is recommended. Because obviously, when they're dead, there's no point in trying to kill it any further, so to speak. The drug of choice for treating dogs is ivermectin, and this obviously interrupts the transmission of the infection from one dog to the next because it actually limits the amount of microfilaria that the adult worms can produce. It will remain a large problem as long as we favor pet ownership of dogs, and hunting dogs in particular and dogs that live in rural areas are particularly infected by this parasite, and so therefore it will always, I'm afraid, be with us. Capillaria hepatica has a global distribution. It's primarily an infection of rodents of various kinds, and humans very rarely become infected, but when they do, it's something to notice because it causes pathological effects in humans as well. The life cycle in rodents involves the adult worm, which lives in the liver of the rodent, and they lay their eggs there. So while there are males and females, they don't migrate out of the liver. The eggs do not exit the liver. In fact, they embryonate and they sit there until the host dies, perhaps from a natural cause, perhaps from predation. Remember, this is a sylvatic cycle mostly. The eggs are then ingested and develop. The infectious eggs could develop inside of a carcass that's rotting in the woods. Let's say an animal dies of natural causes. The eggs then are ready for the next infection. They're eaten by a scavenger. They hatch in the small intestine of the scavenger. They develop to adults in the liver and mate. Egg production ensues, and that completes the life cycle. Now, in humans, I guess we would encounter this infection if we were scavenging. Let's say we were living off the land, and perhaps we encountered a carcass of a large rodent, let's say in South America, a paca or a capybara. Those animals are susceptible to this infection as well. That's a lot of meat to discard, and they're usually not discarded. They're usually ingested and eaten. All of the animal is eaten. And as a result, this infection can result in a human case as well. Of the ones that have been identified in people, they're mostly asymptomatic cases. They're found as incidental findings on autopsy after the patient or person dies of either natural causes or perhaps during an accident of some sort. And these are incidental findings. Rarely, if ever, eggs are found in stool because, as I've mentioned, the worms actually lay their eggs inside the liver tissue, and that's where they stay. In the few cases that are on record, treating those patients with albendazole has been shown to have some effect on the outcome of the infection, but because it's mostly asymptomatic to begin with, it's mostly a palliative treatment, unfortunately. There's no recommendation for avoiding this infection except that when you see a dead rat on the street, I would recommend leaving it there. Now we come to a very serious infection, and in places where this is endemic, this is not a nematode of minor medical importance. This is a nematode of major medical importance. It's called Capillary Afilip, and as its name implies, it's found throughout the Philippines and Thailand. And interestingly enough, recently in Egypt. It's mainly an infection of birds, particularly water birds. But humans can become infected as well, and we'll show how that occurs as we follow the life cycle illustrated here. Let's begin with the infected egg being eaten by an intermediate host. In this case, the intermediate host can either be a crustacean, a shrimp, or a minnow. And the infection is found in freshwater estuaries, which are adjacent to the saltwater transition from a river to, let's say, as it empties out into the ocean. It's a very popular area for people to come and harvest material, in this case, minnows and crustaceans of various sorts, for consumption. And let's just see what happens then when someone actually eats one of these two items in a raw state without cooking. The larva inside the tissue of the intermediate host is then released in the small intestine during the act of digesting the intermediate host's tissue. And the worm then penetrates a row of columnar cells, much the same as the adult worm of Trichinella and Strongyloides does. And this is related in some ways to their biology. The worms then mate, and the adult female begins to shed live larvae, reminiscent of the Trichinella adult. But as immunity develops, the mode of production of offspring changes. It changes from a live birth modality to giving birth to eggs instead. I would say shedding eggs rather than giving birth to eggs. And these eggs are shed as an embryonated egg that then embryonates fully once it passes out of the host into the surrounding environment, at which point it has the opportunity for being ingested by either a shrimp or a minnow or some other invertebrate wildlife. A crab could easily become infected with this as well. The main symptoms from this infection, however, are related to the fact that the larvae that are produced, the live larvae, reinfect the same host. So this is an autoinfectious cycle that in many ways resembles the autoinfectious cycle of Strongyloides stercoralis. And more adult worms can accumulate as the result of this early onset phase of its life cycle. Again, as I mentioned, as immunity develops and limits the number of worms that can establish in the small intestine, those worms that are left start producing eggs, and those eggs then pass out of the host. So what an interesting biology this parasite has of building up its numbers so that it can produce lots more eggs, so the eggs can exit the host and then carry out the infection again. So what are the consequences of infection? Well, with an early onset infection, nothing. But as the numbers of parasites increase, then diarrhea becomes the main symptom. And this, again, resembles the early onset symptoms from Trichinella or from Strongyloides. With Strongyloides, of course, the diarrhea continues. With Trichinella, The diarrhea lasts for as long as the adults are present in the gut tract. When they disappear as the result of the development of immunity, the diarrhea goes away, and then some other symptoms follow. That's not the case here. The diarrhea continues and continues and continues. It's protracted and may even prove fatal. There are other symptoms and signs as well. Vomiting, anorexia are very common as associated with the later onset life cycle mode during the egg production stage when all of the adult worms are now firmly established. At that point, these later symptoms and signs appear. The way to make the diagnosis, of course, is to find the egg in the stool. If one were to look earlier on in the infection, you wouldn't find any evidence of infection at all because the live larvae, all of them, reestablish the infection in the gut tract. Once the diagnosis is made, mebendazole, our old friend mebendazole, or the derivative albendazole, has proven very effective in getting rid of all the adult worms in the gut tract. Now, there's a very interesting local dish that people consume both in Thailand and in the Philippines, and it's got a very interesting name. It's called jumping salad. And the reason why it's jumping is because people who harvest organisms in the estuary bring them back alive. And that's as fresh as it gets, if you want to look at it that way. And these items are then added to leafy greens and served on a large plate to the customer that just ordered jumping salad. It's obviously called jumping salad because the ingredients, most of it, is alive and moving still. And that's one of the criteria for knowing whether you've been served a good jumping salad or not. It's not necessarily how high it jumps, it just matters that it jumps. And in consuming these live intermediate hosts, we subject ourselves to the ravages of this infection. If we were to cook these items first before adding them to the salad, you'd take out the name jumping and add something else, dead salad or a mort salad, something like that. The point of that is that the cooking process would kill the larvae in the tissue of the intermediate host and we would never get infected. But the treatment is effective once the diagnosis is made. So very serious infection can lead to fatalities. Harvesting organisms from the environment without cooking is the problem in this case. Okay, Esophagus bifurcum is a very interesting nematode infection, not a filarial parasite, not related to the Capillaria group at all, an entity unto itself almost. It's found in Africa, South America, and Asia, which means that it's got a global distribution. And mostly it's an infection of non-human primates. The adults live in nodules in the small intestine. They lay their eggs there. The eggs pass then in the feces, embryonate, hatch, develop to L3 larvae. And in that sense, this life cycle is reminiscent of the hookworm life cycle, where the eggs are deposited in soil and then they develop to the third stage. The infection, however, is by oral route only. So, unlike hookworm, which is able to penetrate the unbroken skin, Esophagus is unable to do that. But nonetheless, because I presume that there are some elements of fecal deposition which are undigested, say like whole parts of plants and fruits of various sorts. So non-human primates may actually take advantage of that food source and ingest that, and in doing so, acquire this infection. And so that means that we must have done that too in order for a human infection to occur. The eggs are swallowed as third stage, they hatch, they then penetrate the wall of the small intestine and mature to adults. Mating ensues, females start to pass eggs, that completes the life cycle. Now, in most human infections, Esophagostomum does not cause severe clinical disease. There's abdominal pain. Most infections, however, remain asymptomatic. And the eggs that are discovered are often confused for those of hookworm eggs because they resemble them in morphology as well. Treatment is with albendazole, very effective. Since there are so many reservoir hosts and so few human infections, Virtually nothing is recommended in terms of control measures. Turnidens diminutus is an infection found in Africa and Asia. Again, this is one that infects mostly non-human primates. Almost nothing is known about the life cycle in humans. We don't know how we acquire this infection. And that, of course, suggests that there are no control measures for this, because without knowing how we acquire it, there will be no particular method that we could employ to avoid infection. Iron deficiency anemia is the chief complaint. Again, this is a reminiscent infection of hookworm, so you could easily confuse the signs and symptoms from these two infections, but certainly they have nothing in common in terms of transmission cycle. Otherwise, we would have known about how these are transmitted a long time ago, but we still are unable to piece together this life cycle. Whenever we do encounter them, if they're mistaken for hookworm and you treat for hookworm, Turnidens also goes away. Albendazole is an alternative therapy, which has proven to be effective as well. And now Dr. Daniel Griffin is going to give a clinical vignette illustrating the pathogenesis of this infection.
We have a 32-year-old Thai fisherman from the southern coastal part of Thailand. He's coming in to be seen with 2 months of watery diarrhea. He has significant weight loss. He looks emaciated. He reports diarrhea about 10 times per day and has trouble flushing the stool. He reports he eats normal fare, such as boat noodles, som tam with fish sauce and pickled fish, vegetables, and rice. Now, on exam, he is a thin, wasted-looking, emaciated man with a protuberant abdomen, but no enlargement of the liver and spleen. Now, what about our patient's outcome? This patient had a stool examination, which revealed Capillaria philippinensis eggs, and he was treated with mebendazole 200 milligrams orally twice a day for about 20 days, and he actually did very well. So I would say, even though we relegate these two minor organisms, when an individual has this, or certain areas of the world where these are endemic, it's a little more than a minor problem for these individuals.
So that completes our vignette of nematodes of minor medical importance. If you want to learn something more detailed with regards to the clinical aspects of intestinal capillariasis, also known as Capillary Afilip, John Cross wrote a wonderful article in 1992 that really was a classic case history coupled with clinical correlates, coupled with epidemiology and the biology of this parasite. This parasitology researcher knew everything there was to know about it because he discovered it. And he turned out to be a friend of mine. So I've had firsthand information from him telling me all about how exciting it was to discover this infection among the native populations of the Philippines while John was serving in the Navy in the Office of Naval Research. The next time we meet, we'll discuss aberrant nematode infections. Thanks for listening.